Good morning, and thank you for joining us for today's convening on non-fatal overdose response. My name is Matt Eisenberg, and I'm the director of the Center for Mental Health and Addiction Policy. For 10 years, the center's work has been about helping people with mental health and substance use disorders through policy research. This series is one way in which we share our work with you and spark discussions that matter. I want to express our thanks to the Provost's Office, the university's Nexus Award Initiative, and the Bloomberg American Health Initiative for their generous support of our center in this series. Thank you to the center's Director of Research, Aline Kennedy Hendricks, Director of Policy, Brendan Saloner, Director of Training, Sachini Bandera, for organizing today's convening. And thank you, of course, to the Hopkins Bloomberg Center team, Sam Rosenberg, and the HPM Comms team for all their work. I now have the great pleasure to introduce Mayor Muriel Bowser, the 7th elected three-term mayor of Washington, D.C., who has served the city since 2004. She's led major efforts on substance use disorder, economic development, and public safety while guiding DC through significant public health challenges. We're fortunate to have her here today to speak on non-fatal overdose response and the importance of supporting community well-being. Thank you, and please join me in welcoming Mayor Bowser. Thank you so much.
Good morning, everyone. I'm so happy to be here, and I want to thank Matt for that lovely introduction. And I want to welcome you to Washington. It is great always to be here in the heart of our downtown, and great to be at the Johns Hopkins Bloomberg Center. As I was outside, I was just remarking on how beautiful this building is and what a great addition it is to have thought leaders come to this building to explore all manner of issues. And this is especially an important one to us. I want to acknowledge my team in DC government who are here, especially Dr. Barbara Bazron, who leads our Department of Behavioral Health. Give her a hand. There she is. And I know another DBH team member is going to represent us on this panel. Also, Kiana Creighton, who works as the Chief of Staff for our Deputy Mayor for Health and Human Services, and I think is a Johns Hopkins alum. So, Kiana, thank you for your leadership. So I have had the privilege of being mayor of my hometown since 2015. And since then, we have been very focused on how we build a strong, responsive system of care for residents who are struggling with substance use and behavioral health challenges. We know that we need a system that is grounded in best practice, informed by data, and importantly, a system that is tailored to the lived experiences of Washingtonians. We know, for example, that the opioid epidemic in DC is disproportionately affecting Black residents and men in particular. And that's not necessarily what we see in other parts of America, including kind of the average age of people impacted. We also know that one of the strongest indicators, and I know you're talking about that in today's conference, of the strongest indicator of a fatal overdose is a previous overdose. And that's why we work, the work that you're doing is so critical to our learning and to our practice. And it's why we have also saturated our city with naloxone and in just about every way it could be dispensed, we have considered or are doing. In 2024, we distributed more than 100,000 naloxone kits. It's available at no cost and no ID, and no prescription is required. And last year, for the first time since fentanyl infiltrated the market, and we're very proud of this, and we know there's more to do, but we know it represents lives saved. We saw more than a 26% reduction in opioid fatalities in Washington, D.C., and a 13% reduction in non-fatal overdoses. So we know that consistent and persistent efforts are working here. Part of how we've been able to reach people in a more targeted and strategic way is through our new DC Stabilization Center. We opened the center in 2023. It is a 24/7 facility designed to provide immediate compassionate care for those experiencing acute intoxication from drugs or alcohol. The center also offers behavioral health support, peer counseling, and connections to long-term treatment. And the team at the stabilization center is saving lives. We, through the DBH research and data, determined the best location. It was one of our existing facilities that was built out in a way that was comforting to those, low barrier, walk in, get help, get stabilized, and hopefully connect to treatment. And since its launch, the center has had more than 8,200 admissions, serving 2,600 unique individuals, many of whom have returned multiple times. Dr. Bajron just told me that one individual came 50 times, and on the 50th time, he connected to care, which highlights the need for sustained intervention. The data correlates with what I just told you about the uniqueness of DC's problem. 83% of those admitted to the center are Black residents, 85% are male, and the majority are between the ages of 40 and 49. When they come to the center, they are able to build relationships with staff, and it's our hope and our goal that over time, more patients will open up to the idea of long-term recovery. The stabilization center is also helping our emergency rooms, and so that they can be available for other health emergencies. And with the center, we've been able to divert more than 3,400 people who would have otherwise ended up in the emergency room. Instead, they're getting the care that they need and getting stabilized. We're also expanding these efforts by opening a second stabilization center in Columbia Heights, where we know that there's a concentrated need for additional services. There are also efforts that we are exploring at our DC Fire and EMS so that we can, when encountering people on the street, get them to care. So we are committed to saving lives in our city, and we're committed to learning more about how to do it better. So thank you for having us.
Thank you, Mayor Bowser. And now we'll invite the panel up, and we'll begin the second part of the program. So please come up.
Hi, my name is Alissa Zhu, and I'm a reporter with the Baltimore Banner. It's a local news nonprofit in Baltimore. I cover public health, and most recently, I've been working on a series of stories about the overdose crisis and its toll on Baltimore and Maryland. And I was an alum of Bloomberg here as well, so it's great to be among students and professors. I'm joined by an amazing panel of experts today, and I'm so excited to introduce all of you. So I am here to my left is Devad Sanders, who is the program director for the Newark Community Street Team's Overdose Response Team and Harm Reduction Center. And he leads initiatives that provide life-saving resources, community-based interventions, and data-driven solutions to combat the opioid crisis. Next is Dr. Jean Moise. He serves as the Deputy Director of Adult Services within the District of Columbia's Department of Behavioral Health. Previously, he had worked as a licensed clinical psychologist and in clinical and executive management roles within a number of health plans, behavioral health managed care organizations, and community provider systems. We also have Valencia Lyle, who serves as the Opioid Crisis Response Program Manager at the City of Detroit Mayor's Office, overseeing the strategic allocation of the city's opioid settlement funds. She has more than a decade of experience in program implementation and policy evaluation, having worked to expand services for individuals with HIV and substance use in East Africa and the US. And last but not least, we have Stephen Murray, who is an overdose researcher, harm reduction program manager, and the director of the SafeSpot overdose hotline at Boston Medical Center and teaches at Boston University School of Public Health. He had previously served as a first responder and has had personal experiences with drug use as well as surviving overdoses. So thank you all for being here today and for sharing your expertise on non-fatal overdoses. I think we have a really great discussion ahead of us. And we also have some time set aside for a Q&A. So if audience members have questions, we would love to hear them. Please feel free to use the QR code that's on the screens around us. So let's jump into it. Let's lay a little groundwork. Because everyone comes from a diversity of geographic areas as well as backgrounds, I would love to hear sort of, in your experience, in your work, what are some of the biggest, opportunities and challenges in this field? We can start with you.
And thank you. And hello, everybody. So when we're talking about opportunities, right, one of the key factors is when we talk about community engagement and outreach, right? Being able to connect with people who not only are in high vulnerability zones, but also being able to provide the necessary help in the community in many instances, because they won't go to seek help based on stigma, based on fears, and based on past traumas. How we, with the New York Community Street Team, Overdose Response Team, work in our communities is by strengthening relationships with those who have a higher probability of being where an overdose will happen, right? So we deal with the LTOs. We deal with training in Narcan, those individuals who are both selling and using, because there's a higher probability that they will be there when someone is in crisis, right? Also, when we're talking about opportunities to then garner support and momentum by individuals who don't believe there's a such thing as hope, right? To be able to reinvigorate the idea that people are still people, regardless of the circumstances that surround them. The challenge, we're here. The challenge is in service providers, frontline staff, being able to treat people as well, being able to provide the necessary services to individuals seeking help without re-traumatization, without the stigmatizing at the connection point, without pushing people away because they have their own issues. We have opportunities to change what that trajectory is, especially when we're talking about detox, inpatient and outpatient, because there are individuals who are self-medicating and they want the help, but they won't go if they're going to be treated like crap. I'll pause there.
Absolutely. John?
Thank you. As the mayor said, the Department of Behavioral Health and the DC government have had a significant impact on the severe opioid epidemic we've experienced in DC for the last 10 to 15 years. She's highlighted some of the accomplishments and achievements that we've been able to successfully achieve to date, such as the Stabilization Center, which is having a major impact in terms of an alternative to people who are using and continuing to use to make sure they're safe, to connect them to care. We have an aggressive engagement and outreach strategies that encompass involving the stakeholders in the community, including faith-based organizations, opioid treatment centers, providers, as well as people with lived experience. And the naloxone distribution. We're a national leader in naloxone distribution, as she said. One of the challenges we still have, however, is being such a diverse city and, somewhat with parts of the city not well represented in terms of access to care and quality. We're making a concerted effort to make sure that we're reaching out in very creative ways to those members of our population who are underserved and don't have the same access and privileges that others have. So we're focused across the river, especially. We're trying to do creative engagement. We're considering, we're putting vending machines out there. We're doing a lot of things that are targeting those populations to ensure that they have equal access to services. And secondarily, a lot of people, similar to other cities around the country, are dying from using at home. So we're trying to find creative ways to engage them through the Stabilization Center and other means to try to make sure that people aren't using alone and potentially dying alone. So those are two opportunities, I think, that we're really focused on in spite of our past successes.
Awesome. Excited to get into that further. Valencia?
Yeah, thank you. Yes, thank you. So one of the areas that I would say is a area of opportunity that we've been trying to expand upon in the city, the city of Detroit, is just collaboration. So I oversee the behavioral health interventions. So we have substance use disorder and mental health, but then we're also working closely with the homelessness solutions team to offer comprehensive services to the community, because a lot of the people that we're servicing may have issues with substance use disorder, mental health, and experiencing homelessness. So we've been able to draw upon this spirit of collaboration recently with one of our homelessness solution teams. And this is a street outreach team. So we have a physician, nurse practitioner, and a homeless outreach worker who go out into the community, find people who are rough sleeping, and offer just general primary health care to them. But we realize that a lot of the people that are post-overdose response team visits when they're in the community, a lot of people actually do need primary health care services as well. So through this collaboration with the street medicine team that primarily usually sees people who are rough sleeping and homeless, and they're collaborating with our post-overdose response team to make sure that not only people who are experiencing homelessness, but also people who were providing post-overdose response programs to are receiving that primary health care as well.
Awesome. Stephen?
Hi. Oh, hi. Good morning, everyone. Thanks for having me. I think I would start by saying that the major opportunity is that there are so few health challenges that we face where it's a 100% preventable outcome. So fatal overdose, so not non-fatal overdose, but fatal overdose is 100% preventable. Those are really good odds if we're in the right place at the right time. We can't say that about most other things that are potentially fatal. And so I think that like that as a starting point is important to acknowledge that what we're doing here is dealing with a problem that really is a problem. And I think the good doctor brought it up. A lot of it is happening behind closed doors where people are, they're dying from overdose because nobody's there to help them. And I think that this is driven by a couple of things. And so on the sort of challenges side, I think that the continued criminalization of drug use is still a major challenge to every aspect of the work that we do. And we often think of that in terms of harm reduction, but I think that it impacts all sort of phases of working with people who use substances, from the sort of treatment, treatment through even into long-term recovery. People who are in long-term recovery, being in long-term recovery should be identified as a major risk factor for fatal overdose, because the longer you have where you're day counting and you're talking about your success, the less likely you are to feel comfortable talking to the people in your lives about, what's going on when you return to use. And so that stigma is incredibly isolating. And then, also to the point, in Rhode Island, for example, 85% of people who die from overdose die in their own homes. In North Carolina, that's like 76%. In Massachusetts, it's 60%. So we know that this is an issue that's impacting people in their homes, but so much of the media focus and so much of the policy focus is around conflating drug use with addiction and conflating addiction with homelessness. And so we often think of this as like a big city problem that is happening to a very small marginalized percentage of the population. And that allows a lot of people to just turn a blind eye for a lot of different reasons to some of the greater systemic issues that are facing both people who are experiencing homelessness who do or don't use substances, but also people who are at risk for overdose. And so I really think that so much of the challenge in this crisis is a challenge of, one, understanding the issue, and two, like having open and honest communication about sort of what's going on in people's lives. And until we end the criminalization of drug use itself, I don't see it getting better.
Yeah, it's interesting you brought up the criminalization of drug use, because I wanted to ask everyone sort of, what are the things that we have tried up until this point that haven't worked, and why? So can, start with you, Stephen, again, and work our way through.
Yeah, that's a good question. sometimes I think that we approach things from an idea of like, what can we do? Like what new thing can we do to fix the problem, rather than like looking at all the things that we're currently doing that are exacerbating the problem. And so I often think about systems as being like the obstacle to solution in a lot of ways, because it's really hard to take away programs or take away solutions that are being done for a whole lot of different reasons. Very good example being the entire approach to criminalizing drug users and the majority of drug sellers through law enforcement. There's a lot of money at stake there for the criminal justice system and for law enforcement and for the courts, et cetera, which helps to sort of keep that system in place, even though we know from a really great study that came out about a year and a half ago that drug arrests, for example, increase fatal overdose in the area around where that disruption has occurred. We know that all drug enforcement impacts somewhere between like 4 and 10% of the drug supply at best. And so it's not really a very good disruptor of the supply sort of as a whole. And yet we pour billions of dollars into it. And we've been doing that for a long time. So I think, to me, like, it does come down to this idea that, you know, the thing that we often think about, like, oh, well, we tried decriminalization for 5 minutes in Oregon and we saw overdose go up, right? You can't decriminalize drug possession in one state and think that an international drug supply is going to adjust its potency based off the action of one state. It's doomed for failure. And actually, unfortunately, the way it was sort of messaged and how things were talked about with decriminalization, I think, has hurt our ability to do it on a wider scale, unfortunately. And so we can't conflate decriminalization with overdose either. Decriminalization is important for equity. It's to help people not end up behind bars. It's to help people feel safer accessing treatment, but it actually doesn't change the quality of the drug supply. And the quality of the drug supply is what drives, in my opinion, drives overdose. And so let's talk about decriminalization for what it can do, without kind of like adding on a whole bunch of other things that we think it might do. When I think that, like, there's a lot of really positive things that could come out of decriminalization sort of outside of overdose.
How about you, Valencia? What have we tried that hasn't worked? Why?
So my response will include both law enforcement response, but also beyond that. So when the city sees someone using substances, or maybe who has like had too much to drink, the response would be to send or call 911, send the police to respond, or send EMS. But we're working with an organization to create an engagement center, so we no longer have to, you don't want people to go to jail or go to the emergency room in response to this. So instead of being sent to these other systems, we're creating a supportive environment, or we're working with the organization to create a supportive environment where people can receive food, have a place to stay, receive any medical care that they need, and just recover in this engagement center, which will help the emergency rooms or reduce like waiting times in the emergency room and bed occupancy in the emergency rooms, so they can respond to other emergencies, and people who just need a place to stay can have a nice place to rest and go on with their day.
I'd like to rephrase that a little bit in terms of what have we done that's not worked. We're doing a lot of things that aren't working as well as they could. One of the things that we could do better, I think, is to focus on those folks who have overdosed before. You know, we know those folks are using. We know they're probably not being very strategic about their use or healthy about their use. So we're looking to increase our penetration with those folks, especially because if you've overdosed once, you're probably going to overdose again, and then most likely at some point you may die. So we're trying to interrupt that cycle. We have a co-response model with FEMS, Fire and EMS, so that when they've responded to an overdose and offer transport to a hospital or the stabilization center, if they choose not to do that, we try to take their name and information so we can follow up later. They don't always agree, but obviously that's a goal. So the hope is to try to people on that path, to try to connect with them through the stabilization center or the co-response model with SIMS to break that cycle so that, they're not likely to die from that pattern of use over and over and over again. So that's a real opportunity, I think.
I like that framing.
So there's the cookie cutter mentality, and then there's the merry-go-round of trauma mentality. Cookie cutter, you can't treat someone who does 2 bags a day the same way you would treat someone who does 2 bundles a day. And the idea that you can give them the same dosage of anything doesn't work, right? The merry-go-round of trauma is you'll have an individual who has a chronic health issue and a substance use issue. And if you don't handle one, then they can't get help from the other. So they're constantly being ping-ponged back and forth because the hospital won't help if they have, hypothetically, open wounds, right? So they gotta help with the open wounds first. The detox facility won't help because they have open wounds, but then they're not gonna call the hospital anyway. So it's dependent upon where the person goes to first to try to get help. But here you go, the hospital will help with the open wounds, but they won't help with the substance use issue because the individual may come intoxicated or under the influence. Now they're not offering any help, right? And often you have to have, and this is what we talk about, having the right people, right? Because when we talk about EMT and paramedics, there's a separation, right? Because in the mind of the individual helping a person in crisis, they're looking at them as this is a person I need to help. But on the larger scheme of things, everybody don't think that way. Everybody doesn't see that there's a specific situation that has to be dealt with in a specific way. And so then you have the mentality, like you'll have statistics, right? Opioid overdoses, fatality, Black men between the ages of 44 and 64. And I get a call to go to a middle school because a 14-year-old is overdosing. I got a 23-year-old right now that overdosed 7 times because he got a bullet in his back that's pressed up against his spine and they can't take it out. The mentality has to shift so that the trauma doesn't keep putting our people against the same set of nuances. It don't work. If we don't treat people like people, if we don't change the mentality of trying to connect the people that need help, if we don't see that it's an us mentality, and you have to have the right people doing the work, we're going to still see it unilateral, and it'll never work.
Yeah, I mean, that's such a powerful thought. I wanted to remind the audience too, we will be accepting questions and, you don't have to wait until the Q&A section to start submitting them. It'll be great to, have a discussion between the audience and our panelists. Yeah, of course. Yeah.
Hello, there we go. So just to piggyback off what Davad said around the gentleman with the bullet pressing up against his spine and thinking about things that haven't worked, I think our push against opioid prescribing for chronic pain or for pain has backfired. It's a failing approach. We know that people with chronic pain are using from the illicit supply. I have people that call our hotline regularly who've had multiple doctors that were arrested, and they've had to turn to the illicit supply because they are in pain, and opioids do work for chronic pain. And so there's no reason why a guy who has a bullet pressed up against his spine should be forced to go and look at the illicit market to get pain relief. And so I really, really think that there's a reckoning that needs to happen around this issue. And a big part of that is going to be for people who are involved in this work, people who may be in this room, to think about saying, hey, we gave this a try, and I actually don't think it has had it hasn't had the intended outcome that we hoped it would have. It's actually increased fatal overdose in that population. We see a lot of people who are over the age of 50 dying from overdose right now. I would guess that many of them have chronic pain. We see a lot of people who are dying by suicide who have been associated with the chronic pain community. I see it in social media all the time, like another person who like was having trouble accessing medication, dying from overdose. And so when we think about things that don't work, sometimes it means backing off of things that we tried and being okay with saying, hey, we tried this. We thought it was going to have this outcome. It had this outcome, which was good, but it also caused this, and this in terms of collateral damage. And so it's okay to say that maybe that approach was too strong or didn't work that well or could have been done differently. And it's okay to back off that a little bit and think about how do we keep people safe, especially those who are struggling with chronic pain.
So I wanted to, get your thoughts on what you're excited about, what seems promising, in our mission to keep people safe and to save people from overdosing again. Just, maybe a way to frame this question is, we know that, I'm covering Baltimore, so this hits close to home, but, Baltimore has a extraordinarily high fatal overdose rate and has had that for several years, or a long time, really more than that. And the city also has an incredible opportunity at this moment with the incoming restitution funds from pharmaceutical companies. So I was wondering, in your experience, this is on the ground and in your work, what are the types of interventions that you feel excited about, that you think that leaders should be looking at and investing in?
Can I go? I think that's a great question. I think, speaking for the district, the Department of Behavioral Health is responsible for, as a state authority for the district, setting policy and regs around behavioral health services, certifying our provider network, and developing and working with the mayor's office to manage a strategic plan to combat the opioid epidemic. Pretty successfully, some good results so far, although we have a ways to go. In addition, we're managing the opioid abatement settlement fund. So it's another opportunity, in addition to federal grants from like SAMHSA for our state opioid response grant, which is quite significant, which we've been managing for 5 years. We have an opportunity to bring together different funding streams to do things differently than any one stream can do. For example, a SAMHSA grant can only do certain things. The abatement fund can fund infrastructure in some different areas that the SAMHSA we're not able to focus and fund with the federal grants. So we're looking through the abatement fund, for example, to look at opportunities to build infrastructure in DC, to integrate services in terms of social determinants of health, contingency management opportunities, recovery housing. So the whole focus on social determinants and looking at the person as a whole person, rather than, oh, you've got an opioid addiction, we're going to treat the opioid addiction. That's really important from a prevention and harm reduction point of view, but we got to look at the whole person too. And various funding streams allow us to do that more effectively.
How about you, Valencia? I know this is very close to your work as well.
Yeah. So we are taking more of a phased strategy to addressing the overdose crisis in the city of Detroit. So we just launched a naloxone newsstand and vending machine project, which expands access to, or where we strategically place these vending machines throughout the city. So far, we've actually found that this has been quite successful, and we're ramping this up over time. But we've already heard of someone who saw our team placing the newsstands throughout the city, went home. They saw a family member who was overdosing. So they knew where to go to pick up naloxone, went home, and they actually saved a family member's life. So even a simple project as expanding access to naloxone can be a helpful and life-saving project. But similar to what you said, we're expanding access to recovery housing. And then we rely on peer recovery coaches to do a lot of outreach, which has been successful as well. So we have a behavioral health and shelters program where peer recovery coaches go out to homeless shelters and help expand access to behavioral health services. Like most people are requesting mental health services, but other services or whichever services people are requesting. And then, of course, we have our post-overdose response program, which is the quick response team, which we've been very proud of. That it was initiated in September of last year with a program that's operating at Face Addiction Now, which operates throughout the state of Michigan. But within that short period of time, they've already connected over 1,000 residents with peer recovery coaching services and whatever other services they've requested with these in-person meetings.
Thank you. And Dibad, what do you think about this? What are you excited about?
So our motto is, I want to see you live. What I'm excited about, forward only. Moving forward with our relationship with University Hospital, because medical support has been crucial in helping to save lives. Moving forward in our Narcan for Life initiative, making Narcan more accessible to Black and brown people, but in a manner whereby everybody is empowered to do something, right? And then lastly, in strengthening relationships, right? Being able to not only connect with, more organizations and service providers that can create spaces and bridges to help impact our people, but also to continue building our relationships, right? With like Integrity House and Cura for inpatient, or you talk about Greater Essex and Rutgers Care Center for outpatient, right? So whereas individuals have an option if they want to go in and stay, or if they want to stay out but still get that help. The idea is that we can build bridges to not just save lives, but also help individuals to live and not just survive, but thrive.
Stephen, I was wondering if you could talk about just like give people a description of how the helpline works. I thought it was a really interesting model, and also would love to hear your thoughts on, what you think, leaders should be investing in.
Sure. Yeah. And really quickly on the previous question, I think the one thing I would just say is that I'm excited that we're finally starting to see people with lived experience come to get spots at the table. When I first came to my unit, I was the only, where I work, I was the only person with lived experience on the team. And I've put in a leadership team. My two top folks that work with me, Kimber King and TJ Thompson, both have lived experience with substance use, and 65% of my team of 45 has lived experience or living experience. And the reason why I'm glad that we were able to do that is I think it's our duty as people with lived experience to make it safer for people with living experience to come to the table. I have a lot of privilege that I try to use to create spaces where people who are actually close, I'm no longer close to the issue anymore. I always say, like, my lived experience has a shelf life, right? Like, what happened 15 years ago is very different than what's going on today. But what we're trying to do is create an environment where people are safe to be themselves and to be honest about what's going on, so that we can figure out better ways to serve and have them be part of that solution. So that's for the previous question. In terms of SafeSpot, so for those that don't know, SafeSpot's a 24-hour hotline where people can call in when they're using drugs alone. We are funded primarily by the state of Massachusetts through opioid settlement funds, but we also have now picked up funding in the states of Connecticut and Maine, and we're making some progress in other states as well. The state of Massachusetts has been really generous that they don't force us to put geographic restriction on incoming calls. So we've served people from 35 states and from across Canada. Last year, we had a 700% growth over 2023. We served about 5,000 calls. We intervened in 21 overdoses. And I think what's really great about what we do is that, like, sure, our sort of like stated goal and really what we're there for is to provide people with overdose detection. So they're calling in, they tell us where they are. That's all they have to tell us. We don't need to learn anything else about them. It's anonymous, it's confidential. We serve a lot of people who work in harm reduction or in the treatment community as well. If they overdose, we get them help, and it works. I think what we really do at the end of the day is we give people a sense of value, and that, like, we really have no other agenda besides safety. And it's safety, and it's also fun. I think people are like worried that when they call in, it's really like the serious thing, but like, we mostly talk about like cats and like the weather, and like one of my operators who was talking to someone like all the time, they like ran out of things to talk about, so they started watching the same TV show. so that they had something to talk about when they were spotting. And it's like beautiful stories like that all the time. Every morning I get like a briefing from my overnight supervisor and from my day supervisor of like, what's the cool stuff happening on the line? Like what are people talking about? Like what's interesting? And we learn a lot about people's experience, what they're going through. Most people who are calling the line are really connected to services, and that's why they know about us. So we don't do a whole lot of, we have the ability to do service connection, but people find out about us because they're connected, or they're on Reddit. That's the other way. Reddit's like our #1 referral source. But yeah, I think it's just like a beautiful thing, like to have two people just like sitting there talking. And if you miss the first minute of a call where they're doing the intake, like, where are you? What are you using? How are you using it? Are our 3 primary questions. If you miss that, like you could listen in, like I as like the hotline overlord, I can listen in whenever I want to see what's going on. And if I go in 20 minutes into a conversation, I would have no idea that what they were doing is spotting somebody, because it's just like two people having a normal conversation. I think that's really awesome.
I wanted to get your thoughts too on, what populations do you think that we're missing or we could do a better job of reaching? And, like, how do we do that? How do we engage folks that need help the most?
Obviously, we've all talked about underserved populations as DC and most other large urban areas that have less opportunity to access healthcare and consistent care. So we're focused on that population. That's pretty well known. In addition, we're focused on nightlife workers in many, many different ways in terms of creative engagement strategies, putting vending machines out where they hang out, working with bar owners to give them naloxone and education and information about treatment, construction workers. So folks that are less prominently, advertised as having potential risk, but we're trying to make sure we reach those folks as well, especially if they have a history of using before they go too far down the line, in addition to the other folks that tend to be marginalized and underserved, to make sure we try to reach as many people as possible.
Yeah, I love how creative that is. Valencia?
Yeah. So this is actually something that a lot of people, or population that a lot of people have already talked about, but we are trying to serve the older populations in Detroit, or better serve the older populations in Detroit. And as has already been mentioned, the older Black men are hard hit in Detroit, disproportionately impacted by the overdose crisis in Detroit. So we're working with like residential treatment programs in the city. They're seeing a lot of older patients coming in, but need a more comprehensive coordinated care model to address some of their needs. Maybe, they might need more walkers, or sometimes just coordinating the care within the nursing home facilities, because there's some stigma in the nursing home facilities about serving people who have substance use disorders or using substances. Maybe even they've been prescribed buprenorphine or methadone. So ensuring that the nursing home facilities are actually serving these populations, educating them to destigmatize substance use disorders is just a topic that we're exploring more, and just working on that education, but then also that coordinated care model.
Ditto everything that was said. I'm also going to just add in that I'm really concerned about the trans community. I think that we need to think about the erasure of trans people in this country, and see it as the threat that it is. And like a third of my team are trans identified, and many of our callers are as well. And I'm really, really worried about them and their safety. And I think that often what happens in this sort of situation, and how this plays into the risk of overdose, is that anything that isolates people, like, increases their risk of death. And so I'm just like, this is the stuff that keeps me up at night, is that, like, I think that the more that we are allowing the public, or allowing policymakers to erase their existence, the greater we're increasing their risk of harm from violence, their risk of of suicide and also the risk of fatal overdose. And so I'm just asking people to stand up and plant their feet in the ground on this one, because it really is a major issue.
And I'll end off with two groups: women and individuals under 30. There is a need, because what we're working on right now is a project based on gender-specific barriers, right? Within our community in the city of Newark, women, unfortunately, are going under the radar. Why? Because they have been traumatized in such a manner by the men in their lives and the systems that surround them that they suffer in silence. And it's unfortunate. And until, you have, and I go back to saying the right people, because when you have outreach going into these communities and they're able to talk to women, you talk about the sex workers, right? You talk about women who are continuously being traumatized, not just by the conditions of the environment that they're in, but then the boyfriend who's the pimp and the abuser and the drug supplier. And there's a constant fear they have, but then they still need help. And you can't be, in these particular instances, a man going to a female in this particular climate saying, well, what do you need? Because then do we really understand? No, you have to have the right people prepared to do what's necessary for individuals who need that help. Women are being underserved. They're under the radar, right? And then individuals under the age of 30 are being under the radar, even when you're talking about teenagers as well. Why? Because they're not shooting dope? Because that's where the fentanyl is, supposedly? No, when we're looking at these fake Oxycontin, when we're looking at these fake perks and individuals popping to be cool, and there's a high probability that that pill has been crushed so that the fentanyl can then help stretch it out. And now the overdoses are happening to a younger population, but nobody is talking about it because there are no services for individuals under 18. We have to begin talking about what's happening because we see it in real time and then do something about it.
Can
Yeah.
I add one more? Sorry.
Yeah, please.
Devon just reminded me too, pregnant and parenting people are also incredibly at risk right now. It's a stigma that is experienced is amplified when someone is pregnant. And yeah, we did something really great in Massachusetts recently where it's not an automatic referral to social services when someone is exposed or someone is exposed during pregnancy. So look into that law and think about replicating it in your state.
Yeah, I mean, I think we've heard, about pregnant folks, trans folks, older folks, younger people. I think it's no coincidence that these are some of the most vulnerable in our community anyways. I wanted to turn to some of the audience questions. So with rapid changes to federal funding, how can we sustain overdose response and overdose prevention work? Whoever wants to respond.
Well, I believe that, for example, in DC, we get a substantial amount of funding from SAMHSA for our state opioid response, from our state opioid response grant. And that's from a behavioral health perspective, the focus and the structure that helps us manage our strategic plan for opioid to combat the opioid epidemic. I think it's very likely that stream of funding will be preserved from everything we can see. But I think we need to be prepared that there may be cuts. Okay, so from our point of view, we're certainly considering bolstering our strategies through our opioid settlement fund, which I'm sure are protected from any federal cuts at this point. We're also looking for opportunities to do some different creative things, partnerships with community, so that if one source of funding is eliminated or cut back, that we can maintain the work in partnership with providers and stakeholders and others in the community. So I think it's early, obviously, so we need to figure out and see what's going to happen down the road. But I think we need to stay open and partner with a lot of different stakeholders in the system and spreading the wealth, if you will, and collaborating as much as possible to maintain the strategies that we know are working.
I know you talked about the importance of leveraging diverse funding streams earlier too. Is anyone looking to incorporate overdose prevention sites into their stabilization efforts or in general in their effort to reduce mortality?
Opioid prevention site. You want to
Overdose
prevention site. That's a broad term. I mean, that's interpreted differently. I guess I'm
right.
wondering.
I think the question is probably specifically referring to supervised drug consumption sites.
Well, I run a virtual one. And what I find really interesting about it is that what I've learned through the work that we're doing is no one cares what I do. Because no, I'm serious. Because the reality is that we always think that it's the drug use that bothers people about OPCs, but we're doing literally the exact same thing on the phone. And our governor has been a really great supporter out front about it. And people like to talk about it. And the difference is that there isn't the influence of sort of like the NIMBY attitude. And so it has very, very little to do with the drug use itself, and rather that people don't want these programs cited in their communities. And so I think we've often looked at it as like, oh, this is about the drug use. And this, but it's, I can tell you the drug use part, I don't think bothers people as much as you would think. It's really that they don't want to increase any services in their communities. And this is one they can easily dig their heels in on. You know, it was great. The mayor was talking about the, I guess it's basically like a sobering center. We've had those in Boston for a long time. It's called Spot. The only place where SafeSpot is confusing for people, like as a name, is in Boston because they think that we're talking about the place called the Spot. It was dumb on my part. But I think that like what we do when we tell people like we want to take care of you after you're high, but not in the moment that you're using, is we're telling them that like the most risky point of their use is something that we're not willing to be there for. Like we're not willing to be there at step one. For years, people have had to use outside of these programs and then hopefully get themselves inside. And I can tell you from the hotline that when somebody overdoses on fentanyl, it goes something like this. All right, I'm injecting fentanyl. Okay, cool. Well, let me know when you're done. Okay, cool. All right, I'm going to push it now. Okay. You doing okay? It's that fast. It literally is like they're pushing it and then we have silence on the phone. So if we're not there in that moment, like we've already missed the moment, right? And so to not have that be part of the equation in dealing with this problem is a major it's basically a political negligence, in my opinion, because we're not actually helping people in their most vulnerable moment.
Yeah, how about, you know, DC, Detroit, or Newark, or supervised drug consumption sites part of the discussion?
Dr. Bowser, I'm the director of DBH, Department of Behavioral Health, and I have visited centers outside of our jurisdiction. We're really focused on other strategies right now where we think there's a lot of opportunity to make a difference. So I don't think the political climate is ripe right now in DC. So we're focused on what we can do. And that's not currently in the cards for DC as far as I'm aware.
I went to the one in Rhode Island. I encourage you to check it out if you're in Rhode Island. It's beautiful. They have a smoking area too, which is cool. And it's a wraparound center. There's stuff going on multiple floors of the building. Drug consumption is one small piece of it, but they can like go to one room and get services, and they can go downstairs and get put on medications of whatever they're looking for. They can get their wound care there. It's great. And if people are really worried about open drug use, then why not give someone a place to go inside to do that drug use?
What are some of the programmatic responses to address the rise of non-fatal overdoses that involve polysubstance use in particular? Yeah, what about non-fatal overdoses that involve substances, you know, a bunch of different drugs, not just opioids? How do we respond to those types of overdoses?
So I'll share. We're working with colleague of mine at Harvard Medical there, because we all know fentanyl testing kits, xylazine testing kits. But with the fentanyl testing kit, you know, the idea of an individual taking something that they're about to use to test it to see if fentanyl is in it, and then find out it is fentanyl in it. And like, oh, okay. And we say, you know, all right, if you know it's fentanyl in your supply, go low, go slow. But then in that same batch is xylazine, is benzo, but they don't know. So working with, you know, our colleagues at Harvard Medical, they're working on a testing kit that then tests for several different substances with that same little bit of product, right? Motto is, if you know better, you do better. But the key here is, if you don't know, then what, you know, what winds up happening? The person, and this is something that we see, a person is now having a respiratory issue. They say, okay, I'm a Narcan. Narcan don't work. So they're like, okay, what do I do now? Yeah, I'm gonna call 911, right? Precious time is being lost. All the while, it was Trank in there as well. But who knew, right? So the goal would be is how can we utilize opportunities that are out there whereby we can, one, test for a product having more than just one situation in it that may then cause an overdose, right? And it goes beyond the fentanyl. Two is an understanding the areas in the demographic, knowing that some people are using 2, other people are using 4 different substances because of whatever their specific condition is, right? As we're talking about pain, right? Well, yeah, some people are using opioids for pain, right? But then what else are they using? So now you have the same person that's using the perks to deal with pain, they smoking the weed with embalming fluid. Now you're just compounding the situation. But if you don't talk to the people to know how they're using, what they're using, and what their reason, you can't address it. The engagement is what's going to help make the difference. The opportunities and the testing kits are what's going to help make the difference. But the willingness to want to communicate with people in need is what will make a difference as well.
I'll say that the post-overdose response program in Detroit, which is called a quick response team, they will respond to any substance use. Like they'll connect people, even if it's alcohol. We're not solely focused on opioids. We're just focused, the peer recovery coaching team that responds post-overdoses, they just go to provide anyone with connection to treatment, harm reduction services, supplies, tools, and then just all wraparound services. But I guess to speak to polysubstance use and particularly xylazine use, we have seen an increase in xylazine wounds. So the partnership with the street med team, which has a physician who is very focused on expanding access to services for all populations. The quick response team partnership with street med allows for the xylazine wound care on site for whoever may need those services.
Real quickly, in DC, Office of Chief Medical Examiner tests for like 500,000 substances in the drug supply. Okay, exaggerating, obviously, but it's not a really narrow range. The problem there is there's always a delay in knowing what's in the drug supply today. We learned that after the fact. So we're trying to speed up that process. But at the same time, similarly, our co-response team that responds to overdoses or intoxication with fire and EMS are trying to engage people irrespective of the nature of their addiction or their use. And lastly, the DC Stabilization Center, Crisis Stabilization Center, again, takes all comers. And actually the majority of people that are served in that center, which saves lives, stabilizes people medically, deals with medical and other crises, and refers people out where necessary. Most of those folks are not, who are admitted at that point, do not have opioids in their system. So we're really trying to take a very broad approach and not say we're primarily only focused on opioids.
I know we're up on time, but I will just say
Yeah.
20% of the calls to SafeSpot are stimulant only. So people who are only using stimulants are calling the line. There's a lot of different reasons why. Sometimes they're worried about opioid contamination. Other times there's just nowhere else they can call and talk about their drug use openly and not have someone be like, you need to go to treatment. So we're open to both of those things. About 15% of our calls are intentional combinations. So people who are taking a stimulant and an opioid and mixing them and intentionally using them. So we see that too. And also, like where I sit in my work in Massachusetts is that we have a really robust drug checking program that's being done by the state in partnership with Brandeis University, Dr. Tracy Green. They test the drug supply across New England, and I sit on the advisory board for that work. And so I look at drug samples every day, and I can tell you that in Massachusetts, every drug use event is polysubstance. Some of our drug samples have 10 different active components in them. So active, not inactive, 10 different active components in them. We've even seen like fake Percocets that contained fentanyl, xylazine, bromazepam, and a nitazene in one fake pill, right? So we're in a polysubstance using situation. There is only one fix for that, unfortunately, folks, which is to legalize and regulate the drug supply. So until we do that, that's a situation we're going to be in indefinitely.
Well, thank you so much for this really invigorating discussion, and thank you to our audience for the great questions as well. Let's clap for our panelists.